So in this week, we're looking at neurological aging, which is pretty much the functional and structural changes that can be appreciated in the brain. Now, the brain is one of the least understood organ systems of the body. And so there's still a lot that we don't understand about neural connections, about parts of the brain stem, and some of the deeper functions of some of these areas, and certainly about aging. So the way that the brain ages and some of the functional and structural changes that are associated with aging. So we're going to start off by describing the major functions of the nervous system. We'll talk about the structural and functional changes that are appreciated as a result of time on the brain. And then we're going to speak about two important neurocognitive or neurodegenerative diseases, which are Alzheimer's and Parkinson's disease. So the nervous system is pretty much the super highway of communication for the body and a connection. It's pretty much the wiring system of our entire body. It's sending and receiving signals and communication from the peripheral nervous system up to the central nervous system and vice versa. And there's pretty much this highway of communication between neurons, which are our cells of the nervous system, and other neurons, as well as other excitable tissues like cardiac muscle, smooth muscle, skeletal muscle, as well as our external environment. So there's sensory information that's being picked up from our world around us. There's sight, olfaction, taste, tactile perception that can be perceived and communicated to the brain, and then signals can be sent in the opposite direction. So really the super highway of communication. There are billions of neurons making trillions of synaptic connections. So let's go ahead and review some of these functions in a bit more detail. So we've got muscle contraction for movement and mobility. When we think about all of our skeletal muscles, they are considered to be excitable tissues. And so neurons innervate muscle, and so they bring about the actual contraction or shortening, which is what allows us to move around. There's sensory information, smell, sight, sound, that's also being appreciated and perceived. There's cognition. And cognition is really our ability to understand things, to make sense of the world around us, to reason, and to voice or express our opinions. And so that is also extremely involved in some of the neural connections that are in the brain. There's also other behavioral aspects of our personality. So our mood, our affect, which is kind of the face that we show the world, be it subjective or basically physical aspects of our emotion, anger, temper, all of those kind of nuanced details of who we are, of our personality, and of our appearance to the world are also communicated on neurons via the nervous system. And then we can kind of just think about the overall body function. Here, we really want to zone in on the autonomic division of the central nervous system. So reproductive function, urinary function, digestion, absorption in the GI, glandular secretion, all of those under the surface functions that we're not thinking about, like your heart rate, your heart rhythm, your respiratory rate, all of that is also being communicated by the autonomic nervous system, which is kind of a hidden branch of the nervous system that innervates smooth muscle and cardiac muscle. And so there's a strong association with the nervous system and the identity of a person. So who you are is pretty much a reflection of all of your nervous connections, all of your thoughts and memories and experiences. All of that is formed by and through neurons. The brain also controls and dictates much of our habits. Again, our experiences and our childhood memories and, the nuances and the quirks of our personalities, all of those are created by neural synapses and neural connections, as well as expressed by neural synapses and our neural connections. And so just by speaking about some of the functions of the central nervous system, the nervous system in general, central and peripheral, we can get a sense of how widespread this system is and the consequences of functional and structural changes that would happen in this system. And so when you look at some of those changes, it's important to understand that they're usually minor when compared to some of our other body systems. We've spoken so far about this general frailty, really involving the musculoskeletal system, the joint degeneration. We talked about some of the changes appreciated in the heart, such as the valvular changes, the hypertrophy of some of the chambers. And when we look at the brain, we don't see that type of substantial degeneration or change in the absence of actual disease process. There also is this large amount of variation from one individual to another. So it's really hard to pinpoint things like lifestyle factors, because there's this large variation in the way that some of these changes or risk factors can affect different individuals. And so we may see atrophy of the brain cause neurocognitive disabilities in some people, and we may see atrophy of the brain have zero effects on cognition in other individuals. So a lot of variation in the consequences of some of these changes that are appreciated with aging. What we do see is that the brain's ability to develop and make new neural connections, this is called neuroplasticity. This is incredibly robust in the aging brain. We can appreciate this using MRI imaging, and we usually don't see substantial changes to the brain size with aging, again, in the absence of pathological or neurodegenerative diseases. And so the lack of this significant brain atrophy is really a reflection of two general observations that we see. There is a fairly constant amount of neurons or neural cells in the brain that stays the same throughout adult life and into the elderly phase. Whereas the glial cells, which are our supporting cells, such as astrocytes and other types of supporting cells, the formation of these cells is usually slightly increased with age, and we call this process gliosis. So both of these changes lend to the idea that we don't see any degeneration of the neural tissue, we don't see any degeneration of the supporting cells in the brain either. And so again, in the absence of things like Parkinson's and Alzheimer's, which we'll talk about later on, some of the slight or mild changes that we appreciate with aging are a slight decrease in the number of brain cells sometimes, or the weight of the brain overall. This is usually specific to certain areas of the brain, like the hippocampus, the cerebellum. There's also a small reduction in the amount of neurotransmitters and receptors that bind those neurotransmitters, again, in those very specific areas of the brain, like the hippocampus, that could affect the electrical activity of memory. So the hippocampus is the part of the brain that controls memory. And this is why, as we get older, even in late adulthood, 40s, 50s, 60s, there is that slight degeneration, again, very mild, very slight, in the hippocampal region, in the connections that are seen here, which will reflect the ability of us to maintain memory with age. So it's not a huge or drastic change or decline, but just a small decline in memory that happens with age, which is a natural process. And we want to distinguish this from actual neurodegenerative diseases where you forget things like your name, you forget childhood memories, you forget long-term memories, which are basically more associated with neurodegenerative changes, whereas this type of slight change to the hippocampus really is reflected in more short-term memory loss. So you forget what you had for breakfast this morning, or you forget something small or inconsequential, like someone's name that you just met, right? So that's the type of memory change that we would see in correspondence with this hippocampal change that happens as a part of normal aging. We also see some of the pyramidal tracts of the spinal cord change in the way that they allow us to control our voluntary motor movement. And so this is why we usually have, slight changes to the motor component of our movement, sometimes not as smooth as it once was in young adulthood. The central nervous system generally also experienced a decrease in blood flow and oxygenation. This is primarily owed to the changes in the vasculature, so the narrowing of arteries, especially smaller arteries in the circle of Willis that actually oxygenate and feed the brain. We also see a delay in the nerve conduction velocity in older nerves, in older neurons. So there's a slower conduction velocity or conduction speed of older neurons. And again, these are some of the minute, very mild, slight changes that are appreciated that usually are worse when we have actual neurodegenerative pathological diseases in the brain, but are very slight, very mild, very inconsequential with normal aging. There's also the deposition of plaques in the brain. We talked about lipofuscin and the deposition of that aging pigment in the heart. We also see it here in the brain to some degree, as well as the deposition of plaques that are called neurofibrillary tangles, which again are more associated with when we actually start seeing pathology. So let's actually delve into the details here of some of those functional consequences of some of the slight mild structural changes that we just discussed. So an older adult may have difficulty responding or adapting to new situations. They may have a slower mental processing or just slower, responding to mental processing or slower cognition as a result of the delayed conduction velocity of neurons. They may also just respond slower to stimuli in general. So sight, sound, perception, even just movement because of those pyramidal neurons and the way that they change with aging. Despite this change, if given, enough time and, space to perform tasks, older individuals actually do have healthy brains. They usually generally can remember, like I said, their long-term memories, so their childhood, their early adulthood, well into their 70s and 80s. And I'm sure if you have grandparents, you can attest to this. They're usually good at telling these old stories because they usually hang on to older memories a little bit longer, especially as a progression of natural aging. There may be disturbances with balance and position, and again, movement and coordination, smooth coordination of movement because of those tracts of the spinal cord. And sometimes there may be an unsteadiness to the gait, but not a movement disorder the way that we see with Parkinson's that I'll talk about later on. So just kind of a general slowing down of the gait, slowing down of cognition, slowing down of response to stimuli in general. And so collectively, these changes can pretty much affect their ability to regulate body temperature, to feel pain. They may present with things like burns a little bit easier, frostbite because of their delayed perception to stimuli, and sometimes just being in physical discomfort. So especially for individuals that are not as mobile as others, you really want to be mindful about this. The fact that they may not voice or, vocalize physical discomfort. And so you have to be a little bit more sensitive to some of these changes. And so we got to be especially careful when we're caring for these in older individuals because of this decreased sensitivity to these stimuli. I also want to point out here, this is where we see things like dizziness or fainting spells, or again, this unsteadiness in the gait may be associated to this as well. So the baroreceptor reflexes are sometimes blunted or dampened because of this decreased sensitivity of neurons and receptors. And we know that the autonomic nervous system, which controls our, regulating blood pressure, especially if we stand really quickly from a seated position. And so elderly individuals really want to, take it slow, move slow, because the vascular system and the blood vessels do not respond as quickly as they once did to, let's say, the baroreceptor reflex or response. Oh, wait. So now let's talk about some actual disease processes that are associated with the brain. Um, and again, we can kind of make the distinction between normal aging and disease process. Although again, there is sometimes this blurring of the lines between those two things. So you may have, Alzheimer's type changes in the brain, but you may have different varying degrees of cognitive dysfunction, of movement dysfunction associated with this. And so we can kind of think of them, we can kind of speak about this here as well. So you do also see an increased incidence of these diseases in older individuals, although you don't see it always. So it's important to talk about this as it pertains to aging as well. So the two diseases are Alzheimer's disease and Parkinson's disease. Alzheimer's disease is really a cholinergic disease, a disease of cholinergic neurons. And a Parkinson's disease is pretty much the disease of dopamine or the dopaminergic area of the brain, which involves movement. Other disorders that have to do with the peripheral nervous system, so changes happening outside of the brain and spinal cord, have not been very well investigated or understood. And so we won't really talk about any age-related diseases that are apparent or involving the peripheral nervous system. We do see other diseases that involve the peripheral nervous system. There's Guillain-Barré, there's Lou Gehrig's disease, there's myasthenia gravis, and these affect other parts of the nervous system, but we're really going to mainly function on these age-related changes that affect the central nervous system. All right, so if we look at the brain of an aging individual, and again, there's no way to let's point out here, first off, there's no way to look at the brain or visualize the brain while an individual is alive. There's no such thing as a brain biopsy that happens when someone is alive. And so a lot of the changes that we see with the brain are really post-mortem. And so we see amyloid plaques and neurofibrillary tangles that accumulate in the aging brain. These are usually precursors to neurologic disease. We usually see them in the brain, and they usually tell a story. Again, we don't visualize them before the fact, but we see them post-mortem in brains of patients with Alzheimer's and Parkinson's disease. We sometimes see them in normal, healthy brains as well, and they don't seem to have a functional consequence or any decline in cognitive ability if they're found in normal aging brain. And so these amyloid plaques and these neurofibrillary tangles, this is kind of where we talk about that blurring of the lines again. We can see them as a part of disease process, and we can see them in healthy brain where they don't seem to have as much of a functional consequence. We also see that the aging brain has a diminished ability to kind of clear itself of old, dead, debris, cells, dying or damaged proteins. And so we also see an accumulation of toxic compounds. We spoke about some of the reactive oxygen species that could be oxidative, that could provide oxidative damage in the brain. And so those are some of the types of changes that we see that could result in some of these changes, the plaque development and the tangles, and then eventually this neurocognitive dysfunction. All right, so here is a histological view or histological image of the brain in a patient who had Alzheimer's disease. And again, this had to be taken post-mortem. And what we can see here are the large amyloid plaques. And this is something that's only appreciated in aging brain or in diseased brain. And then we can also appreciate the neurofibrillary tangles here. So these smaller dots that are not seen in normal healthy brain, but are appreciated in aging brain as well as in diseased brain. So let's talk about Alzheimer's first. I'm sure many of you have heard of Alzheimer's. It's a non-reversible brain disorder or neurocognitive disease. It's pretty much, it presents with problems with memory, thinking and cognition, as well as behavioral changes. So we spoke about the fact that the central nervous system also plays an important role in our personality, our behavioral quirks. And so when we see these changes in the brain, they can also impact our behavior, the way that we act and think and speak as well. There are three types of Alzheimer's, and we'll talk about the different types. There are early onset, late onset, and then familial Alzheimer's. So early onset is a rare form. We usually see it in younger adults, so around 40 to 50, and these are usually associated with other genetic mutations such as Down syndrome as well, or other chromosomal abnormalities and chromosomal mutations. It progresses more rapidly than the other two forms that we'll speak about, and so we usually see this progress pretty quickly and become fatal as we get to the late onset Alzheimer's. Late onset Alzheimer's is probably the most common form of Alzheimer's that we see. It's going to be in older individuals. It's going to start at around age 65 to 70 or so. And whether or not it has genetic component is not quite clear. There could be some connection to other genetic mutations that are seen. And that's not very well understood, but there is some thought that there is a genetic component to even the late onset Alzheimer's. The familial Alzheimer's is definitely associated with a genetic component. It's, again, a very rare or a small percentage of the Alzheimer's cases, but it usually affects individuals, again, earlier in their life, so younger adults, so age 40s, not younger adult, but older, let's say mid-age adults, 40s to 50s. And then the genes associated are with the FAD, familial Alzheimer's disease, will typically include chromosomes 1, 14, and 21. And as you can see, there's some connection here with that 21 chromosome, which also represents the Down syndrome mutation. So let's point out some of the, apparent differences with these different types or different stages of Alzheimer's disease. So early stages usually present with, slight mood changes, poor judgment, poor reasoning skills, getting lost here and there, even sometimes in areas that should be somewhat familiar, like your own neighborhood or your own, workplace if you're still working. Difficulty with calculations, with, budget, budget balancing with money, with numbers, with phone numbers, or just numbers in general, calculations and that type of thing, as well as just this overall withdrawing and sort of a slowing down, almost a depression-like presentation. That's kind of the initial way that Alzheimer's will present. The middle stages are usually where it becomes much more obvious, much more apparent. We see gross memory impairment, again, leaning towards the the long-term memory. So forgetting things like who the president is, and that could differ depending on where you live, how long ago that memory would have been created, but just long-term memory, childhood memories, when you had your first child, what was your first job, those long-term memories tend to leave first. We also see aphasia, which is a speech disturbance, as well as loss of impulse control. So behaving pretty irrationally and acting pretty impulsively, anxiety, they may be wondering, again, aligning with that getting lost. Confabulation, and confabulation is pretty much when you just tell lies, essentially. You pretty much don't remember what something is or the details of an event. And so you pretty much just make it up as you go, make up the rest. And that's called confabulation. There's also a progressively lowered stress threshold. So you cannot handle or manage the same amount of stress that you once could, whether it be physical stress, physiologic stress, emotional stress, mental stress. And then there's an impaired self-care, again, leaning to that poor judgment that we see in the earlier stages. So you don't care about your appearance, the way that you look, ladies don't put on makeup, guys don't, shower and take care of their facial hair and all that type of hygiene, self-care that you once did in your adulthood. That kind of starts waxing and waning. And I want to say not just being negligent, because there is the fine line between just being negligent with your self-care, but then there's this gross and apparent and obvious lack of self-care. As far as the late stages, we see dysphagia. With dysphagia is pretty much difficulty swallowing. And so that's a risk for aspiration. And aspiration is basically taking in food contents, liquid contents into the trachea and ending up in the lungs, which can lead to lots of other complications like pneumonia, etc. There's also impaired speech, little or no communication here. So these individuals pretty much have lost, or I like to think of it as forgot. They forget how to do everything. So how to speak, how to swallow, how to walk and talk. They become totally dependent for all their daily activities on healthcare workers and friends and family. And what usually makes the late stages of Alzheimer's fatal is really the aspiration pneumonia that creates sepsis and infection, and that can be fatal. So because these individuals cannot swallow properly, when we feed them, with an oral diet, whether it's liquid or semi-solid, they don't swallow. And so it just kind of just ends up going into the trachea and down into the lungs, and that can happen over time because remember, these individuals sometimes don't have their coughing reflex. Their gag reflexes are also weakened and diminished, and so they won't be able to tell you, like their, food is going in the wrong area, and so that just kind of settles there over time and eventually creates very unhealthy conditions in the lung, which can spread widespread throughout the body, creating this general sepsis, which can become fatal. Let's now speak about Parkinson's. So Parkinson's and Alzheimer's are sometimes usually classified together. They have some shared symptoms in the way that they present, but then they also have some very unique or distinct differences as well. So Parkinson's is really a movement disorder. So it's a loss of the dopaminergic neurons, the dopamine and the dopaminergic areas of the brain really control our movement, the smooth pursuit of our movement, and help us to move, smoothly. And we'll talk about some of the symptoms that we see in Parkinson's patient that kind of allude to this, this function with movement. It's usually affecting individuals over the age of 50. Some of the primary symptoms that we see, and I'm sure we've observed this in some way or shape in our own lives, but basically tremoring or trembling of the hands, of the arms, of the legs, of the face. This is called just tremoring or shaking. Bradykinesia, on the other hand, is pretty much slowing down of movement. There's also muscular rigidity, so very stiff, rigid muscles, and that creates this postural instability, so unable to kind of maintain your posture. And so we also see this shuffling gait as well. So kind of walking very, very slow, dragging the feet on the floor, the shaking, the rigid muscles, all of that is very pathognomonic for Parkinson's presentation. The symptoms usually present on one side of the body. Why this happens is still not clear, still not known. It's thought to happen on the side opposite of the dominant side. So if you were right-handed and left brain dominant, then you pretty much will see signs and symptoms on your right side and vice versa. The reason that it presents that way is not quite clear. There's also an inability to create and maintain facial expressions that can match your mood, your affect. So smiling, frowning, puckering the mouth, puckering the face, squinting the eyes, that sort of thing, those nuances of the facial expression are pretty much diminished. And there's this flat affect. So if you think about someone who has absolutely no emotion on their face, that's the way that Parkinson's patients presents. This is usually because of the rigidity and the slowing down of the muscles of the face and neck, along with other widespread muscles throughout the body. This slightly stooped posture that we see again, together with this shuffling gait because of the imbalance, creates a difficult gait and a difficulty walking. And this will eventually progress to the moderate stage where we see this become much more severe, the motor components becoming much more severe, as well as just widespread muscle cramping, muscle rigidity, and sometimes eventually loss of motor function altogether. So that brings us to the end of our discussion today around neurological aging and the two common aging diseases, neurodegenerative diseases that we see in older individuals, which are Parkinson's and Alzheimer's. So go ahead and reflect on this topic this week, and then come up with one question that still lingers in your mind and post that to the forum. And then also go ahead and answer, do some research if needed, and answer one of your classmates' question by the end of this week.